really for you. It's for our clinical affiliates, it's for our alumni, it's for our faculty, it's for all of us, but most particularly it's for our students. And so I welcome you to this event, which was begun a number of years ago when the College of Nursing celebrated its 25th anniversary. Now you know, this coming April, we will be celebrating 60 years. So you figure out the math. That's never been my strong suit. But you know we've been having these lectures for quite a while. And what is the purpose? The purpose really is for us to come together as a college and as alumni and friends. But in particular, the real purpose for this lecture each year is to bring to the campus an outstanding nursing leader who will help inform us about the issues of the day. A colleague that will be a role model for many of you, a person that will be able to help us think through some of the major issues that confront healthcare and nursing and help give us some direction for the future. And we have been very fortunate over the years to be able to bring to our campus nursing leaders whose names are in the history books or whose names will be. That is what we are going to do tonight. We are going to introduce you to Dr. Michael Bleich. And Michael, we welcome you to Villanova. We welcome you to the College of Nursing. Dr. Bleich, you'll hear a little bit more about when he's actually introduced. But he is at the cutting edge of what's going on in nursing today. All of you, and particularly I hope our undergraduate students, know what the IOM study is. The Institute of Medicine report that sets the direction for the future of our profession. It is very important. It is a landmark study. It is something that is going to guide us and guide your career paths. Dr. Bleich, among many other accomplishments, served on that commission. And so it is particularly timely that when we are at a juncture in healthcare in the United States and globally, and we are looking to and looking into our crystal ball to decide what the future will be and to hopefully try to shape that future, we have people like Dr. Bleich and many other colleagues that are helping us find that path and define it. And so I hope you enjoy him. You're going to find also that he's a very dynamic speaker. So you will enjoy the delivery and you will learn much from the content. And I hope you enjoy the evening with us. And Michael, welcome. We are so pleased. We had to wait 2 years for this man, but he's here. And I want to thank the committee, Sigma Theta Tau, Lynn Desletz in particular, for making it all possible. Thank you. Good evening. I am Dr. Lynn Desletz, Assistant Dean for Continuing Education and Director of that program. This is the 34th annual Distinguished Lecture in Nursing, and as the Dean mentioned, it's being co-sponsored by the Alpha Nu chapter of Sigma Theta Tau. It is really my pleasure to tell you a little bit about our speaker tonight. Dr. Michael Bleich is the Maxine Clark and Bob Fox Dean and Professor at the Goldfarb School of Nursing, Barnes-Jewish College, and he is Vice President of Barnes-Jewish College Healthcare in St. Louis, the largest healthcare system in Missouri. He is known as an energetic and passionate nursing leader. He launched his healthcare career in 1970 and has progressed to hold administrative, education, and consultative roles. Dr. Bleich is nationally recognized in several key areas of expertise, including leadership development, strategic and operational positioning of academic clinical enterprises, clinical systems design, notably in safety net clinics, work analysis and quality improvement, and outcomes metrics to enhance practice and meet regulatory demands. A Wisconsin native, Dr. Bleich received a diploma from St. Luke's Hospital School of Nursing in Racine, Wisconsin, a bachelor's degree in nursing from Milton College, a master's degree in public health from the University of Minnesota,
and his PhD is in Human Resource Development from the University of Nebraska in Lincoln. He has held Chief Nursing Officer and Chief Operating Officer roles in acute care and academic service settings in Wisconsin, Oregon, Nebraska, and Kansas. Additionally, he has national and international experience as a healthcare and academic consultant. He has published more than 50 articles and book chapters on leadership, academic service partnerships, and workforce issues. Dr. Bleich has received numerous teaching awards. He is a member of many organizations and serves on several editorial and organizational boards. He is known for building community relationships, encouraging collaboration among healthcare professionals, and developing leaders in clinical, educational, research, and community environments. Dr. Bleich was the only dean who served on the committee that the dean mentioned for the Robert Wood Johnson's Foundation initiative on the future of nursing at the Institute of Medicine that produced the 2010 groundbreaking report, The Future of Nursing, Leading Change, Advancing Health. The report calls upon nurses to take a greater leadership role in our increasingly complex healthcare system. Dr. Bleich was a fellow in several prestigious Executive Nurse Fellows programs. He is a fellow in the American Academy of Nursing and is certified by the American Nurses Credentialing Center as a nurse executive at the advanced level. In 2011, he received the Luther Christman Award by the American Assembly of Men in Nursing for meritorious service to the role of men in nursing, as well as service to the profession. He received an honorary alumna award from the University of Kansas. He was named a friend of the National Organization of Nurse Practitioner Faculties and was recognized as a Nebraska Nurse of the Year. Please join me in welcoming Dr. Michael Bleich.
Good evening, everyone. Thank you for those very kind introduction. Is the mic working okay? Can you hear it okay? All right, no? No? Okay, we'll get a little closer here then. How's that? Better? Okay, I'll try to stick with my space here so that you can hear. I am thrilled to be here. Villanova is a fabulous higher education institution that creates and really shapes people of the highest values and worldviews and perspectives. I have known people from this university that have transcended parts of my life in various ways at various times. And so when I was invited to be here, it feels like hallowed ground that I should have been here much earlier. So I'm thrilled to be here with you. So thank you for the very kind and warm welcome and for spending time. I know the students are thrilled to be here this evening because after all, you're students and that would be normal. So I'm going to try to do my part to bring some energy to the group here this evening. And we're going to talk for at least the next couple of hours on several issues of importance for the future because after all, you will want to know this because it's your future that we'll be talking about. And try to frame this several kinds of topics into the course of this evening together. Now, if I were to say to you, what does the number 1,658 mean to anyone in the room? I know a couple of you know this, but other than that, does anyone know why that number is important today? I'm shocked. If St. Augustine were alive today, it would be his birthday, 1,658 years ago. So there's your trivia for the night, so we have that out of the way. So, okay, here we go. I use this photo to try to capture a very unique point in time that we are in the world today. Today, people are transcending traditional hierarchical structures. We are using technology I'm sure there's at least one or two of you on your computers right now as we speak. I'm sure some of you are texting, some of you may be using your iPhones because that's the world we live in. We are so connected. We are connecting different people with different ways, with different values in unprecedented ways. And that will only continue into the future. Now, the truth is, I have kind of a love affair with your faculty. I met them, I know of their science, I know of their academic excellence, and they're really very, very special people to me. But you know what? They're of my generation too. And the truth of the fact of the matter is that we had to learn technology. The majority of you, the vast majority in this room, only know of interconnected worlds. That's been your whole existence on the planet. Now, when we talk about this, we start talking about things like mental models. Peter Senge in his work talked about mental models. Really, what a mental model is something we don't have a terrible lot of control over. We are all immersed in the culture that we were born into. We have people that are imprinting on us from the very, we know now, even before we're born. There are environmental factors that shape what our optimum capacity is going to be, how we think, how we're going to feel, so that when we, that first cry, we already have some of that already in our system. That's your mental model. Yeah, you got one. We all have mental models that embed who we are. And that's why when I speak to students today, and I understand you have a very active Student Nurse Association group here. How many of you are engaged in that activity in some way? Fabulous. Good. I have the honor to be with you in Charlotte in April, so I'm looking forward to that opportunity. You represent mental models that some of the faculty, we can't get it. We have our own, you have your own. And I think what I try to represent here is that how the world is becoming and how we transcend and take action on the world is going to be very different. It's going to be led less from a command and control, hierarchical structure, bylaws driven, curriculum committee driven. We're going to be more fluid. We're entering a time and a place where fluidity and capacity is fundamentally changing. So by serving on the Institute of Medicine's Future of Nursing Task Force as one of 18 members, 5 of whom were nurses, it's fascinating that this report was not written for nurses, it was not written by nurses, it was written for one reason, and that is because nursing as a science and as a practice fulfills a social good. It was written to serve the public. It was written from the public's perspective of what they need from us. Not what we decide they need for them, but what they need from us. Now, concurrent with the writing of this report, which, by the way, was very capably led by one of the finest leaders I've ever had the opportunity to work closely with over a 17-month period of time, and that was Dr. Donna Shalala, an incredible organizational facilitator, policy person, again, not a nurse, but who had keen wisdom and energy to share, to bring multiple perspectives, including what the public needed from us as a discipline together. And in that time, we crafted this report. Concurrent to that, Congress is working on something we know now as the Affordable Care Act. And I'm sure you've all been listening to the politics of the last months. Last Sunday, I was in Las Vegas giving a keynote for another group. And it was fascinating because I was asked to address the topic of politics, because the two are different, and how the future of nursing might shape out. And it was fascinating in the sense that I couldn't terribly prepare until the election results came in. Because there's a lot of debate still in our country. There are mental models about what's right, what is the best way to frame the future. There are still conversations afoot about whether or not being and promoting health is limited to those who have access through some kind of insurance, or whether all people should be able to exercise and live in a world where health is enhanced and optimized. So there are these worldviews, these mental models that are still actively being debated. So we're trying to write this report at the same time as Congress is having this very bipolar kind of discussion. And if you remember, that report was prolonged. It was supposed to have been passed in the fall. In fact, it didn't pass until April. And so we're trying to write this report because by law, and the Institute of Medicine, for those of you that may not fully appreciate this, is a bipartisan or a nonpartisan, actually. It's a nonpartisan group of what are supposed to be people that represent very unique perspectives, sponsored by our tax dollars to study social issues. The whole reason the IOM gets so much credit for all of their reports has to do with the fact that this is not a think tank. It isn't a group where we get to brainstorm what we want the future to be. The narrative in that report and the recommendations all must be based on science. So everything that comes out of the Institute of Medicine has been vetted not only by the members who do the work and collect the science to narrate the report, but it goes through at least 2 other review committees, blinded panels that look at the quality of science, the depth and the breadth of the science, so that what comes out is, in fact, useful to the public. Now, I share that with you because nurses seem to think that we should have studied ourselves. Many of them would say, well, it should have been all nurses. Now, think about that. Do you think we would present any kind of bias? I'm going to suggest we would have. The other thing that I very humbly will tell you is that it was hard to explain sometimes to other disciplines how it is we do what we do. We are a discipline that has been embedded in a particular Eurocentric culture. Think about that. Florence Nightingale. Florence, pretty much on her own, decided that men did not have the capacity to care. There were a lot of men in nursing before Florence who decided who was going to look like and be a nurse. There are other nurses that were just as influential. But you see, Florence was smart because we still need to learn many wonderful things from Florence. Florence used data just like the IOM used data. Florence was not allowed on the battlefield of Scutari. She had to watch people die. Now, I'm serious. You just went through Sandy here. Some of you have people that you know you couldn't do anything about. So watching people die is a pretty tough thing to do. Now, Florence didn't just watch them die, kind of thinking, wow, this is sad. I'll take my lamp and write some letters. Florence studied. She prepared a workforce. She took it upon herself to make sure that when the policy and the politics were right, that when she pushed the doors open and lifted up those windows to let out the putrid air, she knew exactly what she was doing. She knew from an epidemiological modeling perspective that we were infecting ourselves as much as we were getting infected from the the root cause of trauma and death and blood. It was infection. And it's fascinating because when you look back at the work of Lister and other people who were her partners, in other words, Florence hung out with some pretty smart people. Nurses, nursing students, one of the lessons from the IOM and one of the lessons from Florence is that we should all hang out with a lot of smart people. It will serve you well. The other thing is Florence didn't hang out with just nurses. She hung out with people that mattered to the bigger issue of how was she going to save lives and make a difference. So I want you to have some contextual appreciation for the parallels that are running here. So this IOM report is evidence-based. It is trying to project what does the public need from us. This portrays a particular point in time where people are taking action and they're going to expect from us something that is different fundamentally than what we have traditionally done in hospitals. Now, hospitals today, and I happen to serve on the American Hospital Association group that's looking at the future of the acute care hospital. And a white paper will be coming out soon that says acute care will be delivered not only in buildings, what we call hospitals, but acute care will be delivered in the home in the next decade or 20 years. That's already beginning to happen through technology, robotics, and other areas. So if you want to be an acute care nurse, a hospital nurse, you might only have to go to your home or to the patient's home to be able to deliver that care. There is a group in Atlanta, Georgia, that I read about several years ago that has decided rather than paying homeowners association dues to keep their yards nice and pretty in this neighborhood, they've banded together because they've hired a primary care nurse practitioner. Because they decided they really loved their neighbors and their neighborhood. And they really thought, why should we invest in daisies and flowers when we could get a nurse practitioner to keep us here? So you can see in these examples that business as normal is kind of being dissipated. Now, why do I share that with you tonight? Because you are Villanova nurses. Because this is a group that I expect you get it at a deeper level. I expect that you come at this with a sense of purpose, a sense of value, and a sense of knowing that there is nursing science present now in enough volume that this report, for the first time ever, captures the essence of our discipline. It could never have been studied 20 years ago because our science had not grown. Now, what is our science, you ask? And I'm glad you did. Because this is the part that we don't do so well. We all know that the public does what with us? They love us and they, T-word, trust us. So for 17 months, I heard about, oh, the public trusts us. We are the #1 most trusted. You all said it, right? Haven't you all said that? We're the most trusted, yay, nurses. But the other side of that is there's a study that they don't know what we do. So on the one hand, we are trusted, but if they don't know why they're trusting us, is it just because we're nice? Is it because we're there just when no one else wants to be there? There's this whole thing, my colleagues, about nursing that we have to learn to give voice to. And that's part of the education and why there's an urgency here and why that's in the title of this presentation. The urgency is this. We are not there simply to be the assistant to any other healthcare professional who isn't there 24/7. Physicians would say, I love nursing. We love them. I spoke to a group of physicians in Idaho. They love their nurses. But then I asked them, well, what's, because they're my assistant. No, that's dominant mental model. Most of you here, believe it or don't, have that as your predominant mental model coming to nursing school. I'm going to help care for others. I'm going to work with the physicians in the hospital. Most likely, that's where you started from. And there's this notion of somehow, and isn't it fascinating that the physical therapist may go home on the weekend and we fill in? The pharmacist goes home on the weekends or the night shift. Who fills in? Nursing. The dietitians go home. Who fills in? Nursing. So can you see how the prevailing mental model is that nursing is an assistive profession? Well, we are. And I think there's a reason why we are. And that's what I want to share with you before I go on into more of the content of this, of the PowerPoint itself. When we think about medicine, medicine spends at least 12 years professionally studying disease and how to treat that disease. And even further, how to cure it. That is their whole mental model. Now, it doesn't mean that all physicians are that, but it is the dominant mental model that drives the field of medicine. And I remind people that come just 1900s, it was like butchery. It wasn't like the science it is today. So you don't have to go back too far to realize this was more kind of, let's just cut them open and see what we can find. And, you know, anesthesia wasn't used all that long ago. So this was not a pretty sight. You can go back and look at some of the history things about why they had this special report done on the quality of medical schools. Physical therapy. I don't know if you've looked around lately, but people are getting old. I can tell you right now, my feet are sore. So physical therapy. They are mobility specialists. They are all about ligaments, muscles, joints, how you move. Does the public care about how they move? If you want to go out and golf and you're 80 years old, you care. If you want to go bowling, even if you want to play cards, you care. This is called quality of life. Occupational therapy, a whole field of science just on activities of daily living. Social workers, family dynamics, how the family functions. So you've got all of these disciplines coming together, understanding their science. I point out to you that nursing is the only discipline that understands the person in the context of the family, in the context of the community. So when people say to you, why do you want to be a nurse? You seem smart enough, you should have been a physician. You might have something to say back to them. You might say something, well, physicians focus mostly on disease, and my specialty is focusing not just on the individual, but the impact of disease on the patient and the community and the family and the dynamics of that. And furthermore, while I've got your attention, and thank you for asking, did you know that we are the only discipline that looks at the patient, the family, and the community, the individual, the family, and the community from a holistic perspective? We're not just fixed on disease. Our science is about illness and how you live with disease. Now, you know every day right now that you're taking care in your simulation labs and in the people that you're intersecting with. Living with illness is a whole lot different than getting diagnosed and named that you've got diabetes. Well, that's where the physician is great. They diagnosed it. Now, here's the treatment and whatever. Nursing comes in. How are you going to live with it? Do we have to wait? Could we abate that in some way? And the other thing that we do, by the way, as long as I've got your attention, we are committed to health. Leading change, advancing health. We're the only ones that believe that the healthcare system, not the illness care system, we're the only ones that promote health. You don't have to get diabetes. We know that with children right now. We're the only ones that seem to understand that we could keep you from even getting it where you wouldn't need a physician to need that diagnosis. Do you understand that? you're very quiet. Like, so, Thanksgiving is coming up. Many of you will celebrate that holiday. And you know, Uncle Harry will talk about his gallbladder surgery from aught in the 1970s, and Aunt Susie will talk about other maybe gaseous problems she's having, or you know, families talk about these things. It's not a pretty conversation to have, but they're going to be turning to you and say, well, what are you learning in nursing? Are you putting in tubes and doing all? And I hope that you say, well, yes, but here's the real deal. This is what your dollars are paying for. You are helping me be a practitioner who is a holistic practitioner who focuses on health and illness, and we do know disease and illness management. And I understand, my science is that I understand the whole role of the family in this and the community. And I have a whole field in any one of those domains where I can choose to practice. Thank you all for your tuition support, and I need another, round for next term. You can be savvy about this, but what I'm trying to get you to think about tonight is that you have to give voice to this. This is a key finding of the IOM report. The public needs to not only trust us, they need to know why they're trusting us, and this is a huge part of that. So when it comes to the IOM report, there are recommendations that deal with various perspectives. One is that the public really wants to make sure there are enough of us. Now, the reality is the election is over, and it looks as though the ACA is going to move ahead. Oh, there's work to be done. Don't be misunderstood. And that work must include the work of nurses. Now, those of you that are undergraduates, raise your hands. You're probably thinking, how do I pass NCLEX and get a job, right? That's kind of a major focus. That's normal. But I want you to think something different tonight. I want you to do that, but I also want you to start thinking about the fact that you cannot be silent even today about helping shape the rules and the regulations that will happen as a result of accountable care organizations and other structural realities that are happening. Because here's the reality. There are very few nurses at those tables. There are very few nurses that are talking about health. And a lot of those models are being set up basically, it's still a disease-based focus. Now, the structural pieces in the law is actually quite good for the public's well-being. But unless you have people shaping the rules and the regulations, and that work is yet to be done, we're going to be missing. And we will find ourselves serving a predominantly illness-based system even in the next 20 to 25 years. So don't think that you can just check this off your list because I don't have to worry about it today. You all really do. We all collectively do. And because you're being developed in such an elegant and exquisite way as professionals, it seems to me that it needs to be an absolute part of your education is how to start attending meetings, showing up in places, using technology. You've got the fastest texting thumbs I've ever seen. You know how to reach the world in ways that people of my generation can be trained to do, but it is not natural for us. Your voices must be heard. We need the public to continue to accept a nursing voice. So the next time you go and introduce yourself to a patient, say, I'm here to give your care. I'd like you to start thinking about things like you could do just even on a small basis. Hello, my name is Mike. I'm going to be your nurse today. I suspect today, and this is in a hospital setting, I suspect your physician who will come in will be paying attention to your disease and how your treatment's moving ahead. You might see the chaplain today who might begin to talk about some of the spiritual dimensions of what your illness means. But I'm here as your nurse because I'm going to be working not only with them, but I'm going to be attending to how you're doing with your illness. I'm going to start attending to what support systems are out there for you. And I'm going to start connecting you to resources and people, because that's part of our science, and that's what we do as a discipline. One by one, individual by individual, we start imprinting a message about why the public needs nurses and why our science is a critical piece to the health care system. I will tell you, there is no great medicine anymore without great nursing. So we have to play enhanced roles. The public wants us to do primary care because they know we can. Again, when you think about what primary care physicians do, they do look at the patient primarily from disease orientation. Nurses will look at the disease and also the illness and the family, and they will make those connections. So there's the Venn diagram of life, there is that period, that overlap. But the nursing model must prevail. One of the things that's happening in this state is a model for expanding the scope of practice. Now, for those of you that think scope of practice is just for the advanced practice nurses, I am telling you that every day nurses go to work and we are sub-optimized because of institutional policies, procedures, and practices. And there was proof here a couple weeks ago. When Sandy swept through this area, did you notice that everyone did whatever needed to be done? We didn't have policies and procedures and protocols. If you knew it and you had that knowledge, skill, and ability, you went and did it. We saw it when we had the World Trade Center scenario, where there weren't people double checking and checking off the checklist to make sure all of the procedural checking was done to check. How many of you have had an experience where you've done nursing in another country as part of your educational experience? It was very freeing, wasn't it? Because all of a sudden, you could take all your knowledge, skills, and ability. We have to work for institutional level change, where the expert nurse in diabetes is not held to the same level of practice as the novice nurse, who may need to be very protocol driven and get help around that. In other words, we have to optimize every day our human capacity. So part of the IOM report speaks to scope of practice. We have to have people that are leaders and comfortable dealing with two things. One is evidence-based practice. Have any of you ever heard of that? It's a new term. EBP. Why? Because we sit on science and we don't use it. So now everything is kind of evidence-based practice. Well, that's really good because we know a lot. And as a result of evidence-based practice, we know there is a best way to do certain things. So for example, in critical thinking, by the way, how many of you have been taught critical thinking? I hope you're being taught critical action just as much. Because here's a good example of critical thinking. That's VFib. Okay, end of story. That's critical thinking, right? So I love it when nurses say, oh, they don't know how to critically think. Yeah, they do, but, you know, and here's the other issue around critical thinking. That's VFib. Let me check it for 4 or 5 minutes to make sure. There's a timeliness, there's a temporal element to critical thinking. You've got to do it fast enough. You've got to pull it together. But we also know from science, evidence-based science, that there is a best way to do things. So here I am, I've got my defibrillator, I'm going here, okay. Bzzzt, all clear. Okay, I just defibrillated the patient, a physician, 3 nurses, and a respiratory therapist. So the reason we need evidence-based practice is because there is a best way. We should shout all clear before we defibrillate, then push on those buttons. You know what I'm saying? This is part of the evidence. But here's the other part of this, and this is where schools, we're just not doing that great yet. Education is failing us, and that's in the area of innovation. Because I'm here to tell you today that when acute care hospital goes into the home, or when acute care is done in a neighborhood setting, or if it's done in a long-term care setting. We don't know. There's no script for that. So the other side of evidence is the lack of evidence. And leaders have to, nurses who are great leaders are people who have self-confidence based on the evidence and the principles and the values that you're learning here. That's why I think this is a great school. Because I want you to leave and say, if a Katrina hits or a Sandy comes in, that you're not cowering because I don't have the script for that. You have to improvise. I mean, tonight's Dancing with the Stars night, right? You could be home watching the results show. There's an improvisation that has to happen. It is a dance. And you don't always know. And that's the part of this. So we do have to have academic standards, and we have to have science to continue to expand. So we're making some real differences, but we're also still struggling. We don't know how to balance workforce with public need. The knowledge we have around supply and demand, we can hardly count the number of nurses. There is no counting of physicians. There's no real accounting for pharmacists, physical therapists. We don't even have the number of people that are out there and being trained. We don't even have a basic, there is no plan. We lack it. And this again is the paradox. It's paradoxical in some ways. Because on the one hand, we have people debating the federal government, we shouldn't do this nationally. Okay, well then where are we going to do it? Well, we'll do it locally. Well, if we do it locally, we'll never know. Because the East, the West, the South, I mean, it's rural, urban, frontier. I've lived in frontier parts of the country. Team-based practice, if you're in a frontier area, is kind of makes me smile. Because often you're the only practitioner in the whole county, which might be bigger than, you know, some of the states here on the East Coast. So who's the team? You know, we teach in simulation how the team is going to come together. I ask them to do a simulation where it's just the nurse. Because you're the team. Now here's where technology comes into, but you see, we don't teach the innovation side of that. So how do we deal with this tough stuff? So we have to have contextual knowledge, and we still have to build cohesion within our discipline. So I'm just going to tell you that we need to be passionate, we need to message, we need to be risk takers, we need to stick with it, we need clarity of our purpose in terms of the public's good, and we need strength of character. And that means we have to get nurses not only at the point of care, but we have to start showing up at local meetings, public meetings. We have to be there. And you know, nurses tend to be perfectionistic. Have you noticed that about yourselves yet? How many of you love to be the first to raise your hand when the faculty members ask you a tough question? Or do you kind of just, we'll wait and see what Bob answers first. Good old Bob, he's always putting himself out there. Ooh, ooh. That didn't work so well for Bob. I think I'll just be quiet. We can't go that way. We have to learn to be at the table because we keep thinking someone else, until we get it perfect, we're very, again, Eurocentric, perfectionistic. Florence was nothing if she wasn't rule-driven. Rule-driven. Evidence. Chop, 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 chop. Now, she herself wasn't, but everyone who, she trained them to elevate the standard. You have to understand the context. You have to realize that everyone at these policy tables today, there is no script. They're making it up too. What we haven't figured out as a discipline is we could go make it up with them. We could do the dance and just throw it out there, and that's going to sound pretty good. Now, why is it going to sound pretty good? Based on what I just said, why is that going to sound so good to them? Because we understand the person in the context of the family, in the context of the community. And none of them do. We understand that it's not just about diagnosing and then treatment at the end of life and high cost and whatever. We understand that sometimes, if you're a good nurse, at the end of life, it's just you. There is no monitor. There is no medication. You're the instrument. is just you in contact. And you know it can be a beautiful thing. Other disciplines, they want to still do more tubes, procedures. Let's try one more thing. Okay, and here's grandma. Grandma is like, hasn't been grandma for 6 months, but we're going to do another set of procedures. For what purpose? To lose the dignity. It's just so sad. We need to be at these tables. So we have to get the public aware. We cannot be silent as a discipline. So here's what I say. We have to unify to express this message. We are the sole discipline that approaches health, disease, illness, and chronic care management with the knowledge drawn from a model of holistic care. We make decisions, provide and orient treatments, and take other critical actions, there it is, critical actions, based on our independent observations, not just those of others. I mean, we're talking about interprofessional education. It isn't sitting there to be homogenize everyone. We're there because we bring a unique perspective to the interprofessional table. So we want to do independent observations and team-based plans. We are the sole discipline that hardwires mental models you with the perspective of the patient client within the context of the family and community. And care is coordinated and managed according to this context. That's what you need to have in your heart, in your soul, in your voice when you go home for Thanksgiving holiday. So when they want to know what you're studying, it should sound something like this. And again, remember the lenses. So, for those of you that are in faculty roles, students, pay attention because you're going to be faculty soon. We have to rethink education. Students, why you need to listen into this? You need to help us. Use technology, push simulation, push engagement. The thing about this particular generation graduating is that you really are very nice to those of us that are more senior. You really are. You let us go off and do our highly structured, ritualistic things. And while we're doing that and meeting and figuring it out, you're out doing it. We'll catch them up later. Interprofessional education is a perfect example. We would be 1,000 years ahead if faculty just stopped trying to do it, because the students are already doing it on their own. You have figured out how to meet, where to meet, what you're going to do, which countries you're going to go serve it. You already are doing this, and we're trying to have meetings to figure out what are we doing. So you've got to act. We have to start being part of the health system dialogue, the accountable care organization development. And we have to continue our science. I am so pleased that there are some of you here that are becoming practice scholars and scientists to expand in terms of doctoral education. We need scientists to do this. Now I'm going to speak just for a few minutes on another IOM group. And that's a group that got together based on value and science-driven healthcare. This is a group that looked contextually not at nursing, but I want you to see the congruence between what this group recognized. We have to pay attention to the culture around us. So when you talk culture, we have to be able to influence that. We need to think about how we design. We only have 45 million or so people this next year going to show up outside the door for health care. Now, do you think anyone seriously in any health system has really thought about what that means? Do you think before a few weeks ago we could ever imagine Sandy? It was beyond us. And I'm telling you, this is Sandy. This is Sandy. This thing right here. 45 million people are showing up in a year. How are we going to do that? How are we going to give access? These people will have access. Are we going to all put them in the hospital? I don't think so. We've got to go to them. We've got to rethink this. So we've got to design care for in a scalable way. Nurses are really tidy and nice. We like little groups. Oh, here's a little program, a little palliative care program. It'll be 3 of us, and we'll take 9 patients and the families, and it'll be so cozy and nice. The problem is you got 40,000 people that need it, and we're just happy because here's our 9. We don't seem to have moral conscience about scalability. There is a moral consciousness about this, that when we teach leadership in health systems, scalability should be one of the key things we talk about. I don't even hear us talking about it. That's a little problematic from my view of the world. We have to think about how do we look from the public's perspective. I'm telling you, they all think we have bachelor's degrees, most of them. They never knew there was 14 different ways to become a nurse. They're quite surprised to find out. And yet internally in the discipline, we're just like, that's where we're stuck. They want to be part of decision making. There's a whole area of decision science. And I could talk a little bit later, but I'm running out of time, so I'm not going to probably get into predictive analytics. It's a very thrilling topic. You would like it. You're my friend, I can tell you, we're bonding. She's going to be my expert in predictive analytics. If you go to the Student Nurse Association convention in April, I'm talking to you about predictive analytics. You're going to be my key point person there. We have to tie outcomes to cost, and not outcomes as we know them, outcomes as the public expects them. You know, we know the outcome. And you know, the tricky thing about outcomes is at what point in time and whatever. There's an outcome to everything. The fact that I'm in this suit is an outcome. You should have seen me when I got off the plane. You know, so we can say, well, there's my outcome. Look, he's here, he showed up, but did I really deliver? What impact is this going to have? We won't even know, but we're going to try to measure it along the way. Heart sounds, bowel sounds, lung sounds, beetle pulses. Heart sounds, lung. How many of you are just like, I'm so busy, I'm so busy. Heart, hey, got to assess the patient, got to assess the patient. We teach assessment obsessively, but we don't treat intervention. Public health, community assessment. If we do one more community assessment, I'm not saying you don't need to know how to do an assessment, but for pity's sake, someone use the last 15 we just did and do something to fix the problem. It's a huge issue. We got to tie this together. When I was in Kansas, there was a scenario where we had the highest rate in the country of amputation from diabetes. And we wanted to spend $30,000 more to do another community assessment. And moi, the nurse at the table with all these other nice healthcare professionals, I just said, time out. Not going to happen. I'm going to bring in a patient who just lost his leg. And I'm going to have this patient tell you he can't work. He used to be a virile husband, and he's been reduced to this psychological mess. His wife doesn't know how to deal with him. The kids don't know how to deal with him. And we're going to spend $30,000 more to assess that people are losing their legs. And you won't give me $15,000 to go into the beauty shops and teach the beauticians how to look at people. Oh, and oh, by the way, the reason they have their pedicures done is they're too big to get down to their feet. I'm serious. I knew this population. You won't fund us to do that, which we could stop it from getting to amputation right there. We have these perverse incentives. And at the same time, no problems or questions asked when we chop off the leg. Now notice how delicately I put that to that group. We have to speak where people will listen to us. I think I did put the kibosh ultimately on another assessment because we already knew. We have to learn to intervene to get to outcome. And we have to figure out what the outcomes are. What is this endpoint vision? And that deals with how we shape knowledge, how we use health information, how we tie data together, how we use digital technology. And by the way, even the most impoverished people have some kind of cell phone in this world. And major telephone companies in Africa have sent used phones over so that we're able to track epidemiological data to understand health, disease, and its transmission, and we're able to do interventional work. I need you to think about your interventional role, your capacity as innovators. I wish you had 3 or 6 credits where you all had to develop an app. I'm dead serious. You want to be a leader? That means a leader is different than a manager. A leader means you walk through the door and you have to invent. So I wish you all had to do that, to think about some translational way. And that leads to how we trust the interprofessional work and trust the community and how we lead. I'm going to end this evening because our time is really out here. I'm going to talk a little bit about a colleague that I feel like I know. I'd love to meet this man. Edgar Morin is a philosopher from Europe, and he's not tied to healthcare. But for the faculty, I would strongly recommend thinking about Morin's work. He really talks about the issue of just being educated today. Now, we have a problem with education. One, in our country, and I look in this room and I see a definite gender imbalance. This is mostly what we're going to see in all colleges, liberal arts colleges. You're not going to find men. In our country, they're not going back to school. We have a major cultural issue when it comes to gender. Women are going to be it. You always wanted to be. I don't think under these circumstances. Now, this is an issue for nursing because based on Bierhaus and some other work that I've done, and you'll see an article in the January edition of the American Journal of Nursing on issues around gender. Because of several major life events, and again, because of time, I'm not going to go into history except for to say this. We cannot solve the nursing healthcare workforce issue in the next 15 to 20 years unless we get gender balanced. And we are the least of all the health professions when it comes to gender recognition. Most medical schools today, 40 to 60% are female. Most occupational therapists, about the same. Home health aides actually are pretty gender balanced. The only discipline in all of the health professions that is repressed down to about 6% is nursing. And if we do not recruit culturally diverse people and attract them in to this discipline, our discipline will no longer exist probably as we know it in the next 20 to 25 years. I mean, we're at that level. And again, it's like Sandy's coming, and so we're just not dealing with it. So we've got to gender recalibrate. Now, Morin says there's such a subdivision of all of the disciplines in education that we're treating everything, our knowledge is, and I'm going to, again, pull this all together. We don't teach enough about the human condition. We blind our science with such a narrow methodological rigor, whatever, that by the time you finish the postdoc, you're probably like, you got a perspective about this big. But you're highly intelligent about whatever methodological or statistical prowess you might have. You could explode your head with the science of science. But it's making us narrower and narrower. And Morin says we're living in an era of, fundamentally, our science is filled with error and illusion because it's not contextually bound. We've lost it in our rigor. So we've got to figure out what's pertinent to know. We need to teach the human condition. Now, in the scheme of life, nursing gets this, but we have to have MBAs. We need accountants who understand that it's not just nurses can bear the burden of knowing about the human condition. We need to understand Earth identity. Morin says we are on a global planet in a trajectory. We don't acknowledge it. We still have great debates in our country about whether ecology and knowledge of the environment is even tied to what is pertinent to becoming educated. Morin goes on to say that we need to spend a huge amount of time, and this is kind of where nursing is like, we spend so much time on algorithmic, protocol-driven. We need to teach you really your life is going to be filled with more uncertainty than any of your faculty or myself have ever experienced. So if we're not teaching you how to be resilient in the face of uncertainty, we're failing as educators. And that means a comprehensive perspective, and then we also have to teach from an ethics perspective. Now, I've tried to talk a little bit tonight about the whole notion of the IOM report, why it's relevant. I haven't done it in the conventional, here are the 4 key messages, and here are the 7 key recommendations and whatever. I've tried to, tie in a little bit about academic and life perspective. I've tried to get you to understand at some level that each of you matter. Each of you are the instrument that will bring this discipline to its full fruition. And even if you're still working really hard at being the best you can be in terms of individual patient dynamics, and you're working with the family, and even if you're at that level, I wanted to give you just a little bit of elevation to understand that you're part of a stream of consciousness that is sweeping the country and, in fact, the globe, and that nursing represents a science that is incredibly important to the world and how we will experience life. So that's the essence of what the challenge is. And here's my wish for you as I end on this birthday of St. Augustine. I wish that you will continue always in your personal evolution. I'm 60 years old at this juncture, the same age as this school. I continue to work on being a nurse. It's never done. This last year, I lost both of my parents. As sad as it was a blessing to experience that dimensionality in my life. I'm a better nurse today only because I've lived life through that experience. You will never stop being a lifelong learner. And somehow when faculty tell you that, I know it sounds really like, okay. I really mean it. If you stop evolving in your own connection, self-awareness, self-understanding, to the huge shifts of what's going on around us, if you don't get into the stream of what you are missing out, what we so need from Villanova nurses. Not every nursing school presents a liberal arts context and perspective, a worldview perspective. It's missing in many nursing programs. That is why I believe strongly in the Villanova nurse leaders that I know that have inspired my life. That's what makes it a different experience being here. So I want you to take advantage of this opportunity, celebrate your point in time. Every one of you students here understand what Margaret Wheatley said is this: if you put your hand in a stream of water, that stream is forever changed. I want you to leave here tonight knowing that every one of you is an instrument of change for the purpose of health and well-being for our society, and I applaud you for that. Thank you for letting me be your guest this evening. Thank you. I know there's if anyone has any questions, I've been asked if I would take some. I'm welcome to do that, or I would just be willing to stay here for a bit and take them individually. Does anyone have anything publicly? I know that time is... Let me just stay publicly, and if you have some questions, I'll be glad to answer them one-on-one. Thank you once again.